At this point, I would like to turn the floor over to Sari Schumann, who is a research public health analyst with the Aging, Disability, and Long-Term Care Program with RTI International, who is going to do some intros and guide us through the rest of the presentation for today. So thanks for being here today, Sari.
Thanks, Steve. Welcome to the webinar today, everyone, on Lewy body dementia. In this webinar series, the Administration for Community Living's National Alzheimer's and Dementia Resource Center has partnered with the American Society on Aging, and we're pleased to have all of you in attendance today. Before introducing our speakers and beginning the presentation, Erin Long from the Administration for Community Living will provide a brief welcome.
Hi, everyone. Thank you so much for taking the time out of your day to join us to learn about Lewy body dementia from Angela Taylor and Robert Bowles. We are very excited to have them here to inform us and are looking forward to learning as much as we can in the limited amount of time that we have. So thanks, everyone. We are good to go. So back to you, Sari.
Thanks, Erin. Today, as Erin mentioned, we're hearing from Angela Taylor and Robert Bowles about the importance of comprehensive care and support with Lewy body dementia. Angela Taylor is Director of Programs for the Lewy Body Dementia Association, and she serves on the Advisory Council for Alzheimer's Research, Care, and Services that oversees the National Plan to Address Alzheimer's Disease. Ms. Taylor also was a caregiver for her father who had Lewy body dementia. Robert Bowles also joins us today. He's a retired pharmacist who was diagnosed with Lewy body dementia in June of 2012. He's now focused on dementia education and advocacy, and his mission is to teach others that there is life beyond diagnosis. So without further ado, I'll turn it over to Angela to get us started.
Thank you, Sari and Erin, for the invitation. We're excited to be here today. All right, for the objectives for today, you will be able to list at least 3 symptoms of LBD. You will identify 2 ways that LBD is different from Alzheimer's disease, and also be able to identify 1 class of drugs that should be avoided. All right, to make sure we're all on the same page, let me just give an overview on what dementia is. In very simple terms, it's a change in one's cognitive abilities that affects your ability to perform tasks of everyday life. Most of us, when we think of dementia, the first word that pops to mind is Alzheimer's disease. But they are not synonymous. Alzheimer's disease is one form of dementia, but there's actually many causes. And there's multiple areas of function that are impacted by dementia, such as language skills, memory, and like the ability to exercise good judgment or understand how things relate in 3-dimensional space. They're all different cognitive skills. Dementia can be caused by many different things, some of which are treatable, like changes in brain structure, such as by a brain tumor, or medical conditions like thyroid disease. But what we're here to talk about today are the progressive dementias, and Lewy body dementia is one of those. Alzheimer's disease is the most common, and Lewy body dementia is the second most common progressive dementia after that. It is the most misdiagnosed form of all types of dementias. It's often initially diagnosed as either Alzheimer's disease or Parkinson's disease, but can also be misdiagnosed initially as a psychiatric disorder. In the brains of people who have Lewy body dementia are these little protein deposits, and they were discovered in 1912 by Dr. Friedrich Lewy, and later on they began to be called Lewy bodies. And so that's why this disorder has the strange name of Lewy body dementia. Many people have never heard of the disease, and it makes them think it must be rare. But in reality, it's not at all. We estimate that it affects about 1.4 million Americans, plus their extended families, of course, who are going through this disease side by side with them. Slightly more men than women are diagnosed with LBD, and it is, like Alzheimer's disease, a disease of later adulthood. Most people are diagnosed after the age of 50, but we are seeing some people develop it a little bit earlier than that. The term Lewy body dementia is an umbrella term. It is not a single disorder, but it's actually 2 different disorders. People who develop Parkinson's disease and then later develop dementia are diagnosed, that dementia is diagnosed as Parkinson's disease dementia, and it's one form of Lewy body dementia. The other is diagnosed as dementia with Lewy bodies when a person presents with this form of dementia, but they may or may not have Parkinson's-like symptoms at the same time. Those generally come around the same time or later in dementia with Lewy bodies, or DLB. So when we talk about this umbrella term of Lewy body dementia, we're really talking about symptoms in 5 areas: cognitive changes that progress to dementia, changes in movement, which is called Parkinsonism, or symptoms that look like Parkinson's disease, changes in behavior caused by psychosis or mood disorders, changes in sleep, and also changes in the autonomic nervous system. This is a very complex disorder that affects more than just cognition, and because it affects so many areas of a person's life, comprehensive clinical care is extremely important. There are a lot of things about this disease that can be treated so that it improves the quality of life of not just the person with the disease, but also their primary caregiver. One of the reasons it should be diagnosed early is that people with LBD actually respond better to medications that were originally developed for Alzheimer's disease. And so they have an opportunity to benefit from that right away. But on the flip side, they also are at greater risk for medication sensitivities and side effects to a range of different medications, such as antipsychotics, which are the medicines used to treat hallucinations, and hallucinations are one of the symptoms of LBD. So you can see we have a catch-22 in this disorder, where you have a lot of symptoms that might need to be treated, but then some problems with the actual medications themselves. And because of its complexity, family caregivers really need early education and support, and to be guided toward resources that will help them. So I want to present some of the challenges that this disease presents to families, and then I'm going to ask Robert to share with you why we feel that there's also messages of hope. This is a complex disorder to diagnose. Not only does it vary the combinations and the severities of the symptoms at the beginning, but not all of the symptoms are well reported, and it's not very easy for a primary care doctor to diagnose. So generally require people go see a specialist to get this diagnosed. It's challenging to treat. Like I said, there's a lot of symptoms that can be treated, but some of them require a delicate balance between the medications that are used, so that you don't treat one symptom but then make another one get worse. And right now, there are no FDA-approved drugs specifically for dementia with Lewy bodies. There are clinical trials going on now, but all of the treatments are actually developed for other disorders. And so we have a long way to go yet to make this disorder a little bit easier to manage with medications that are safer. As many people never heard about the disease until Robin Williams passed away, and it was found upon autopsy that he had this form of dementia. So for the most part, the first time people hear about it will be in the media like that, or when a loved one is diagnosed with the disease. And so they don't, at the beginning, have an innate sense of what this means to them. Shortly after learning about the disease, caregivers get a little bit of a surprise to find out that they have to actually carry forward the message about what this disease is, and not just telling their friends and their family, but also some healthcare professionals as well. So they need to become educators and strong advocates. And last but not least, as I mentioned, not all healthcare professionals are familiar with LBD and the sensitivities that families experience. And so families must be very proactive when they go see a new provider, especially if they find themselves in a hospital environment. The emergency room is a place where people often go when they have strong changes in their functional behavior, functional abilities rather, or behavior, and there they may be exposed to medications that may be dangerous for them. So it is a challenging scenario for families to navigate. However, one of the important things, one of the things I'm really excited about is Robert here is living and breathing example of why we feel there's reason to be optimistic. So Robert, will you share with everybody some of the things that you think are helpful to the person when they're newly diagnosed?
I think one of the most important things that for the person being diagnosed and also for the family is to accept the diagnosis. Back in 2013, I came up with the ASAP squared, as soon as possible, accepting the diagnosis unconditionally. That means in the head and the heart. It takes both of them to get past it. Maintaining equal or greater socialization. We all need socialization, and the tendency is to isolate, and that tends to decrease the quality of life for the individual. Have a positive attitude. Sometimes that's very difficult, but we need to try as much as possible and find our new purpose in life as soon as we can, because purpose, we're all driven by purpose, and that will help us keep moving forward.
Wonderful. Now, for the caregiver side of things, early information about the disease helps them feel like they're a competent care partner and partner with the physician. They also need to realize that while they're caring for somebody else, they also need to care for themselves. And they need access to people who are going through similar situations. And so helping them find access to the LBD community is a really important tip that you can take into your work environments. Recognize and reducing their own stress, as it has a ripple effect on the person they're providing care for. And recognizing that they are going to be a key component of ensuring that their loved one is getting comprehensive clinical care for all of the symptoms of LBD. So I want to break down the disease a little bit more at the symptom level and talk about what they're like and how this really affects everyday life. And Robert's going to share some examples as to how they've affected him as well. So when we talk about cognition in Lewy body dementia, memory is one of those things that can be impaired early on, but it's not typically as impaired as somebody who has early Alzheimer's disease. So you might see some forgetfulness, but not as severe. More than likely, what they'll actually have is a change in executive function. And so that's the ability to do problem solving or think about abstract or analytical things. Sequences, doing things in order, and keeping all of that straight in their head is difficult. Attention can be greatly reduced, so that they may not actually be taking in information in the first place to remember it later. They also have some changes in speech patterns where they may substitute words inappropriately, and they may have problems orienting themselves spatially. So it looks different from Alzheimer's disease when you do neuropsychological tests, and so it really can be differentiated, but you have to go beyond the typical primary care level into the neurologist and possibly into the neuropsychologist to get all of the information you need on the cognitive skills. Robert, tell us a little bit about how your thinking has changed and how you're coping with the change in functional ability.
That certainly is an important part of the disease itself, and early in the disease process, it's often seen. For me, I was able to, but prior to diagnosis, and I could multitask. I could do 6, 8, 10 things at the time. Now I have to trim that down drastically, sometimes to 1 or 2 things, and sometimes not even 2. But what happens is I have a processing and retrieval problem. That symptom becomes very difficult for me in the sense that if I'm talking with someone and I pause, we take for granted that when we communicate with someone that we listen to them, we process what they say, we formulate a reply, and then we carry out the reply. There's a delay in the sequence for me and for most people with Lewy body, to where I start the conversation. If someone interrupts me thinking they can help me, then that puts me in a very difficult situation that produces anger, because I become almost like an inanimate object standing in front of them with no idea what to do next. So when you're communicating with someone with Lewy body, give them time to finish the sentence. If they need help, they'll likely ask you for it. but it takes time sometimes to process that reply and execute it. I've been in Walmart before, where I walked in with my daughter. We start to leave. We're at the back of the store. I have no direction of where I'm going. That difficulty in spatial issues and those type things with it. Reduced attention, just being focused and then not focused. Those are frustrating. I tend to manage them well, with the exception of the interruptions when people do not give me time to finish my thought process.
Absolutely. So one of the things that can be done is the treatment of cognitive symptoms with a class of drugs called cholinesterase inhibitors. And these are medications developed for Alzheimer's disease. You hear them advertised all of the time. Not one of them is better than another. When it comes to LBD, they all seem to be helpful. But beyond that, plan to slow the day down. Don't plan on doing as many things in the same amount of time. Make sure you build in breaks and naps. Managing expectations both for the person with LBD and the caregiver is really important. We can forget that the capacity has changed over time, and we reach different stages where we have to rethink what we can get done during the day. And also, both not just for the person with LBD, but also the primary caregiver, learning to ask for help is vital. LBD cognition fluctuates, and by that it's different from what you might think of when you think of sundowning in Alzheimer's disease. Within the day, within the hour, a person may have changes where they go from clear-headed to confused, changes in their ability to concentrate or pay attention or take in their surroundings, and they also may be excessively sleepy during the day. That's one of the measures that they can use to determine if somebody's having fluctuating cognition. Robert, how is your attention and what changes are you experiencing day to day within LBD?
My attention will fluctuate a lot of times based on mood, those type things. Oftentimes people do not think about the emotional component that is seen in all dementia, excuse me, but especially in Lewy body, those emotional components that can change on a dime. I've had I did a blog several years ago about 6 brains in one day. I started off the day slow moving as a result of the osteoarthritis. I moved into a happy stage, talking with my wife, and we were just carrying on and having fun, and I got happy. Then all of a sudden, I started just giggling, laughing. Never done it before to that extent. The day progressed. I went into my office to do some advocacy, and I went into a stage which I coined as tired brain syndrome. My brain just seemed tired and fatigued. Well, I've always pushed myself beyond human limits, and that's been a difficult thing for me, and I tend to push beyond where I should stop. I moved into a stage that I coined sizzled brain syndrome. My brain was as if it was a skillet, and it was just sizzling. And still not stopping, I finally went into a stage that I coined fried brain syndrome. And that was actually just a shutdown of, there was nowhere to go. I couldn't think. I didn't know what to do. And I was forced into just going to the recliner and resting, recovering, and then bouncing back. That one changed me to where I learned quickly after that I needed to slow down and not try to do as much in one day.
Absolutely. And one of the things that I think, I saw consistently with my father is that when he had a very full day, he wouldn't just be exhausted at that day, but he might have lowered functional ability the next day or two, where he might sleep excessively long, or he might be overtly confused compared to his normal baseline. So really managing that, the cognitive resources and the energy is really, really important. One of the things that's helped a lot of people.
2 to 3 days to get over.
Exactly, exactly. One of the things that's helpful to some people, and neurologists may prescribe this if they're, sleep disorder specialists, are the use of psychostimulants to help people maintain their attention better throughout the day. And that really seems to have a benefit from a quality of life standpoint. When we talk about Parkinsonism, again, those are the symptoms that look like Parkinson's disease, and that actually manifests itself in a couple of different ways. Stiff movements, changes in a person's walk so that their feet are shuffling, definitely balance problems. Falls are a frequent problem in LBD for several reasons possibly. People with LBD may have a tremor, but it typically is less pronounced than what you see in Parkinson's disease. They certainly have much slower movement. I remember my father walking much more slowly through a store, and it working well for me to link arms with him as we walked. It would help him move at a more normal pace. But they also experience changes in their facial expression where they really have reduced expression, making you think that they're sad or not responsive, and really it's a motor problem. Their posture may stoop, and eventually they'll have changes in their vocal volume, and that will progress over time to having swallowing problems as the disease advances. Robert, can you give us a couple examples as to what Parkinsonism has been like for you?
Parkinsonism has been one of my major factors, and I have actually gone through all the symptoms she's got there and some additional ones. Freezing of gait, I've had that, which that's typically seen a lot in Parkinson's disease itself. I have found some ways to compensate for that. I had one physician where I had watched a video, and he said he had a patient that would keep wads of paper in their pockets. And when it happened, they would throw the paper onto the floor and then try to step over it to break that brain cycle. I've had freezing of hands, playing brain games, and the hand just doesn't move. Had situations where I got up one morning and was coming out of a room, and in essence I said, "Brain, go forward." I went backwards. Didn't think too much about it that day. The next morning, came out of the same room and said, "Brain, go forward." I went sideways. I went to the left. Well, I thought about it a little while, and I said, this has to be a processing and retrieval issue. I am trying to move too fast. I'm trying to move faster than my brain has sent the signal to the muscle. So I called my physical therapist and asked him about it, and he said that's exactly what it is. So I learned to compensate for that, and I believe strongly in finding ways to compensate for loss because this improves quality of life. But in doing so, I slowed down and do not move as fast. The same thing is true in making turns on a corner.
Absolutely. So safety is a real issue when we think about Parkinsonism. As this symptom progresses, often it will need to be treated, but we have to be cautious again from a medication standpoint. The medication that is used to treat these symptoms can actually bring on or worsen visual hallucinations, which is a symptom we're going to talk about in a minute. So unless these symptoms really are impairing function and quality of life, if they're mild, it's better to let them go untreated. But physical therapy, occupational therapy, and speech therapy have a really big role early in the disease. So we encourage people to talk to their doctors about pursuing those. Certainly, you have to assess the environment for safety issues, cluttered environment, loose carpets, wires, etc., because if you're dealing with motor impairment to begin with, you don't need physical obstacles on top of it. And one of the other sections of symptoms that's affected is the autonomic nervous system. And so this is the system that manages all of the automated processes in our body, like temperature regulation, blood pressure, heart rate, etc. And what we see is that a number of these things start to malfunction. So that leads to people having a blood pressure problem called orthostatic hypotension, where when you and I stand up, our blood pressure is supposed to rise, sending more oxygen through the blood to the brain. Well, people who have LBD may not have that rise in blood pressure, and so they're not getting enough oxygen. They may get lightheaded. They may even faint. My father actually fainted during Mass one day, actually twice. 2 different days. So this is an issue that can cause a safety problem. Temperature regulation, hot sweats, cold intolerance, heat intolerance really is a quality of life issue. Urinary incontinence early in the disease, that's another trigger to make you think maybe this isn't Alzheimer's disease, because this can happen quite early on. Constipation is a chronic problem throughout the disease and must be aggressively managed. One doesn't think about digestion when we think about dementia. So this is an example why we call this a multi-system disorder, and why we really have to look beyond what's going on at the thinking level to how is the rest of the system working. Lastly, they may have some episodes of unresponsiveness, whether this is a form of the fluctuating cognition or whatnot, we don't know, but it can be really distressing to families, and often when it starts, they may, take the individual to the emergency room to find out there's nothing evidently wrong. Robert, tell us a little bit about how your autonomic system is functioning and what changed for you.
The first thing was the drop in blood pressure, which was defined as neurocardiogenic syncope. I would stand up and just hit the floor, take about 10 steps and hit the floor. This became so problematic that the electrical cardiologist had me on 7 tablets a day to raise my blood pressure and 2 a day to lower it, and I was still passing out, hitting the floor. It was at that point I was referred to a neurologist and ultimately to a cognitive neurologist, and the cognitive neurologist immediately put Jobst waist-high stockings on me to control it. He said, we've got to get you off of all of this medications. I can't give you some I need to give you because of this. Within 3 months, he had me off of all of that medication, and with the waist-high stockings, we were able to control it. And a year after my diagnosis, I had visited my son 2 hours away, and I was by myself driving back home. I stopped 6 times to use the bathroom. Urinary urgency is a big part in the autonomic dysfunction. Constipation, I went through an 18-month period of time, beginning in December 2014 and continued for the next 18 months. I explained during that time to several physicians, including specialists, that I felt like seemed to me like it was likely autonomic dysfunction. Each one of them indicated that it was not. And as it turned out, I watched the Michael J. Fox webinar on constipation and Parkinson's, and they said it was autonomic dysfunction. They explained the things I had been saying, but they gave management skills. I had reached a point of having total bowel and bladder incontinence sometimes, and was able to overcome it with proper treatment. So you have to continue to push to find the answers.
Absolutely. Now, changes in sleep are very common. Most people with LBD have at least one sleep disorder. Common ones that you're familiar with, like insomnia or restless leg syndrome. Well, the most common is one that I had never heard of until my dad was diagnosed with it, and it's called REM sleep behavior disorder. And that's when a person physically moves about in their dreams. When I dream, my body is immobilized. I'm not kicking or thrashing or shouting or anything like that. But my dad was, and he would get injured, he would hit his bed partner, so it was really a problem. So spouses often wind up sleeping in a separate room if this isn't treated. It's important that all sleep disorders are identified and treated in LBD, because when a person with LBD isn't getting good sleep, their cognition is going to be even worse. Robert, how about you? Are you dealing with too many sleep issues?
Oh yes, those are probably the most can be some of the most stressful symptoms that you go through. I had one night early on or soon after diagnosis that I was swinging my arms in the bed, my wife told me, and all of a sudden I popped out of bed. She said I hit the floor, and when I came to, I had hit the floor with both feet and was hollering out, "Boy, I hit a home run then." So I guess I was playing baseball. Also, I've had times of where one night I had a situation where I could had audio and visual hallucination with it. And we'll get into that in a minute, and I think I'll just wait and share that one then, Angela.
All right. The one thing I want to highlight here is that, okay, is REM sleep behavior disorder can be well managed. As my dad's neurologist said to him, one pill at bedtime can really make a big difference. So make sure that people are being assessed for sleep changes. One of the most concerning symptoms to many families are the ones that are behavioral. So visual hallucinations, seeing things that really aren't there, delusions, thinking things that have no foundation in truth, mood changes like depression, apathy, which is simply a lack of wanting to initiate meaningful activity, and anxiety. All of these things can go hand in hand with dementia. But one of the big indicators that you're probably dealing with LBD and not Alzheimer's disease are visual hallucinations early on in the course of the disorder. So, Robert, can you give us an example as to one of the visual hallucinations you had?
I've seen small babies in the bed, small puppies, gold spots, those type things. A lot of my hallucinations involve dream acting combined. I've had situations where I would have audio hallucinations, visual hallucinations, nightmare, and dream acting taking place all at the same time and not really waking up. I even had one night when I could hear two people talking in the background, and to me they were talking about they had my phone, and they had gotten my medical information, they had gotten my other information, and they were about to get my financial information. None of that is on my iPhone, but I was hearing them talk about it, and as I woke up, I had my left palm open and was taking my right fist and pounding my left palm as if I was hitting my iPhone trying to destroy it. Those are emotionally, you become very shaky with those emotions that take place when those things happen.
Absolutely. And so one of the things that we need to look at is when are these things severe enough that they're really causing distress for the person with LBD. They're making it difficult for the caregiver to take care of them, perhaps because they're distraught or they become care resistant. One of the long-term strategies is the medications used for the cognitive symptoms, these cholinesterase inhibitors. But also, recognizing the fact that this is part and parcel of the disease, you cannot rationalize their way through this. You can't reorient them to reality often. These are just simply too vivid. So, accept where they are. Walk into their reality with them. Respond to the emotions that they're expressing and not the facts of what they're expressing. And then, once they've had an opportunity to feel reassured, then you may be able to redirect them. The thing that's most important to keep in mind is that if anybody has a sudden change where their behavior becomes dramatically different, or their functional abilities take a sudden plunge, that's an indication that something biological is going on, or they may be overtired or overstressed or overstimulated. So make sure you consult a physician if somebody is suddenly experiencing a lot of changes. Now, I know that a lot of people on this call aren't going to actually be doing the treating, but so what I want you to do is just take away that the biggest thing to know about psychosis in LBD is that trying a medication for hallucinations, which are called antipsychotic medications, is typically the last thing, not the first thing that you do. So we look for other causes. Is there an infection going on? Review their medicines. Are they on the right medicines to start, and are there medicines that may be worsening things? For example, the Parkinsonism medicines that I mentioned earlier. Look at their environment. What's going on? Is there an interaction with another person or an object that is kind of building some frustration in their daily experience? So again, just remember that because of the medication sensitivities, the antipsychotic medications always are a balancing act and have to be approached very, very cautiously. Now, the big question, now that we've talked about what the disease looks like, is how does it compare and contrast to Alzheimer's disease? And we'll do the same thing also with Parkinson's disease. So when we look at the proteins involved, there's absolutely no biological connection. two different kinds of proteins in Alzheimer's disease called amyloid and tau, and a different one in Lewy body dementia. The symptoms in Alzheimer's disease, when you get diagnosed, are predominantly cognitive. But we've talked about how many broader symptoms there are in Lewy body dementia, like Parkinsonism, autonomic changes, early visual hallucinations, and the memory may be still more relatively intact. So very, very different when you take in the bigger picture. When we look at it, when we compare it to Parkinson's disease, we see some more similarity than differences. They actually have the same protein implicated in both disorders called alpha-synuclein. And what we do see is that the order the symptoms present may be different. So we said Parkinson's starts with motor symptoms. A person who presents with dementia with Lewy bodies may not have Parkinsonism at the beginning, but over time they may develop it. In fact, they most likely will develop it. Certainly, people with Parkinson's disease, when they get diagnosed, most of them may have no or mild cognitive changes. They will not meet the criteria for dementia. People with dementia with Lewy bodies always have dementia at the time of diagnosis. So let's talk a little bit about some practical matters, some issues that we really just want to highlight that are apart from the disease. And Robert, because he is becoming, he is the expert in all living with Lewy body things, he's got some words of advice about preparing for the office visit. Robert, if you're on mute, we're not able to hear you.
Oops, thanks.
There you go.
Yeah, sorry. My pharmacy practice helped me prepare for this. I think it's important to make notes in between office visits. Jot down every symptom that might change. Now, keep that list, and about 2 days before the appointment with the physician, review it. You can remove those things that are not problematic still. Then you can also, if you've thought of something else, you can add it. But then this must be narrowed down. Physicians only have a limited amount of time. So we must narrow it down to the top 3. We must go in there efficiently. I have always chosen to have that list, give it to the nurse when she checks me in. She gives it to the physician, and he can come in, quickly look at it without me telling him with my slow thought process or a family member trying to do it, and take care of it. It's important through that process to talk about things that if there are motor symptoms that are problematic, there are programs out there that can take care of those. You may have to ask the physician. They may not say anything about physical therapy, occupational therapy, or speech therapy. But all 3 of these can be an added bonus in the treatment of the disease process. And such things as there are programs out there by a company that help teach you to think big, to help with the gait and those type things. There are programs out there for speech where the voice gets soft and low. And those type things can improve quality of life and also be beneficial to the caregiver in having that release of that stress of what's taking place.
Absolutely. And then the last thing that I'll mention, and this is because by this point in time, a lot of families may not be going into the doctors as regularly. In the advanced stage, recognize that hospice really can make a big difference in both the caregiver and the person with LBD's life by coming in and helping early. Let's not, I think there's an opportunity to not wait until the dying process has begun, but actually, start asking for it if in your mind you're thinking, would it surprise me if my loved one or this individual might pass away within the next year or so. That's the time to start asking whether or not hospice might be able to provide some benefit. I do want to mention driving, which is an important safety issue in LBD. There are a number of things that may make a person with LBD unsafe to drive early in the disease. So it's not so much about getting lost, but it is about their ability to respond appropriately behind the wheel. Certainly they could get lost as well, but the reduced attention may make them not notice that the car in front of them is stopped. Certainly slowed thinking, their responses will be slower just from a thought process. Their spatial awareness is going to be off. They may have a visual hallucination that somebody is walking across the street in front of them. May require they slam on the brakes or veer off the road to try to miss somebody who's not there. And ultimately, they also may have motor changes, which make it harder for them to respond smoothly and quickly when they're driving. So I encourage caregivers to think proactively on this issue and to really trust your own gut on this. If you have a concern that this person is not safe to drive, then that's a conversation you need to have with the doctor. Rely on that doctor as a person who can make an objective recommendation or tell the person with LBD that it's time for them to stop driving, and certainly look into the community resources that may be available to help them have alternative ways to get to places. For the caregiver, having been there myself, I will say that we often put ourselves last, and we need to view ourselves as important to care for as the person with LBD. Because if we don't, we run the risk of depression, anxiety, being socially isolated, being plagued with concerns of self-doubt. This actually is very common in LBD because it's not a disease where we can turn to somebody else who's already been there, done that. We're often trying to make our way in what seems to be strange territory without a guide. And then ultimately we risk burnout. Some of this is just the nature of the disease because it's so complex and so many things change early on, but also the challenges we have in getting a diagnosis up front really can make us burdened before we even get to a diagnosis, where we just don't know what we're dealing with and we don't understand what we're seeing. The lack of public awareness is a challenge because nobody intuitively understands what LBD is, and so they don't know where we're probably going to be struggling or how they can help. And certainly as a new caregiver, many people aren't familiar with dementia, what resources out there are helpful to individuals. So I think that puts the LBD caregiver at a place where they may go unsupported, and it's going to take a team approach from the family to the provider to help that individual in the caregiver role navigate this disease and maintain their well-being at the same time. Robert, can you share a little bit about how you and your wife handle those kinds of challenges?
Our challenges can be very complex since my wife has rheumatoid arthritis also and receives infusions for those. But to me, my concern is about her and not myself. And I say that in all sincerity because I see the toll that the disease takes on her. I consistently encourage her to stay active, to get away from me, to be able to go to quilt with the ladies, to go to Quilt Guild, to just do things that she enjoys doing, and to have that social interaction because that's important for her. She does not need to live with Lewy body every moment of every day. And I have found caregivers to be very stubborn. And I'm not attacking caregivers. My mom died with Alzheimer's. My dad with vascular dementia. I understand caregiving. But at the same time, I find across the nation that caregivers tend to be stubborn. They have trouble asking for help. And you've got to ask for help. You've got to depend on family, friends, church, whatever mechanism you got. But I would encourage you to be proactive in that and to build a platform for things to be taken care of because you never know when that moment might occur that you need some help. We actually have a list of about 25 people, and we live in a county that's only 26,000 people. But we've got a list of 25 people that are willing to drive me wherever I need to go without Judy having to be involved in that part. Are they willing to take me anywhere? Are they willing to do this? Are they willing to do it for her? Are they willing to bring food? Whatever the need is. Build those resources.
Absolutely. And one of the things that was most helpful to me was to connect with others who were in the LBD caregiver community. To me, there was nothing like hearing from somebody who was in exactly the same trench, who could kind of set me straight about my own expectations and about what was reasonable for a single caregiver to do. So I absolutely encourage you to help LBD families find and connect with others in the LBD community. One of the things that we are hearing repeatedly is that LBD-specific caregiver support groups are more valuable than to the LBD caregiver than a mixed support group for different types of dementias. So, you know, there are good reasons to funnel them into where they can connect with others dealing with the same disease. Last but not least, help these families really get to the resources that they need early on. We hear far too late that many people are looking for resources when they are already in a crisis stage. Many people don't even know what resources are out there for them. You guys are in the trenches. You know what those resources are. So help educate them about what's available, the benefits of using home health services, respite care, things like that. And I know when it comes to long-term care, and especially Robert and I have talked about this quite a bit, is, you know, looking early for the different communities, if that's an option, if that's something that your family feels is a reasonable resource for you. In LBD, admission generally comes earlier into skilled care than what we see in Alzheimer's disease, and that's driven by two primary symptoms, Parkinsonism and behavioral changes. So we need to be proactive and we need to be prepared. All right, so that's the end of our presentation. We hope that that was a helpful overview about the disease.
It was wonderful. Thank you so much, Angela and Robert. It's great information for everyone who's here. And we do have quite a few questions that have come in. If you have questions at this time, you can enter them into the question and answer section of your webinar that you see on your screen. And we'll get started with some of the questions that have come in. Angela, this is probably a good question for you. A few people have asked about how a specific diagnosis of Lewy body dementia is made. If you could talk a little bit more about that, about tests that might be involved. Is there any specific specialist that would be up to the task more than another specialist? If you can talk a little bit more about diagnosis, that would be helpful.
That's a great question. So in LBD, certainly a referral to a neurologist is one of the most important things we encourage people to do. About 2/3 of diagnoses are made by a specialist. Primary care makes very, very few diagnoses because of the complexity of the criteria and their the nature of their practice. So, you know, a neurologist will do a number of things. They will do, you know, a medical history, a neurological exam, a physical exam. They may order blood work. They will certainly try to rule out all of the other causes that might be behind a person's changes in their functional abilities. They might order an MRI to look and see what structural changes there are in the brain. There is no single imaging test that can say, that can detect the presence of Lewy bodies in the brain. There is a scan that is detecting a change in the amount of dopamine-producing cells. This scan uses nuclear medicine to suggest or identify that something in the Parkinson's Lewy body realm is going on. And so it doesn't differentiate between several different disorders, but it can point doctors in the right direction. Ultimately, it's like with many other disorders, their goal is simply to identify the most likely cause for their symptom when there is no single simple test that will rule it in. Ultimately, the only absolutely definitive way to get a diagnosis is after a person has passed away and a brain autopsy is done. But clinicians can make very accurate diagnoses because we now know how common things like early hallucinations and REM sleep behavior disorder are in this disease, while they are not common in Alzheimer's.
Great, thank you. Robert, a few people have asked, how did you first realize something was not right, and when did you first go to a doctor for your symptoms? You might be on mute.
I forgot that.
No worries.
I went to a doctor about 6 months prior to me selling my pharmacy in December 2010. I felt like something was wrong, but the physicians could not find anything wrong. I had just finished 5 years on the executive committee of the Georgia Pharmacy Association. In my year as president, I was gone 120 days from the pharmacy. So I thought I might just be tired. So I sold the store so that my wife would not be left with a pharmacy in case something happened to me. As it turned out, the day I put my keys in the door, I became depressed. I no longer had my patients to love on, care for, educate, and encourage. I saw a counselor 5 months later. She sent me to a psychiatrist. That doctor added another antidepressant. The 11th day of treatment, I went catatonic, and that's when I started virtually catatonic, and that's when I started passing out. It progressed on for a total of 18 months. I saw 8 physicians in 18 months before I got an accurate diagnosis. And when I got that, the doctor said, everything you have going on is Lewy body dementia. In retrospect, 5 years prior to my diagnosis, I had a knee replaced. I went home from the hospital against my will. I told the physician I was not ready to go home. He told me I had to. And the second night, I saw ants going up. It was going up the wall. To me, I expressed it. The ants are going up I-75, 900 miles an hour. They're going so fast they cannot change lanes. And at the same time, there's a party going on. There's cobwebs all over the place. There's people talking and lampposts and all this stuff taking place. As it turned out, I was admitted to the hospital, still without a diagnosis, and 5 years later, I'm diagnosed. I've been told that was likely Lewy body then, undiagnosed, and ironically, my middle child was working for me at the pharmacy, and she told me about 2 years before I sold the pharmacy, she said, Dad, says, I think you are starting to get early onset Alzheimer's. I said, no, I'm not. My memory is grossly intact. 2 months later, she said, Dad, I think you're beginning to get Parkinson's disease. I said, no, I'm not. Doctors did not agree with any of that either. As it turned out, she was right on both of them. And the symptoms were there, but it was not picked up. And that's not uncommon.
Thanks for sharing that, Robert. Can you talk a little bit about memory loss and Lewy body dementia? A few folks have asked if it's something typical that occurs for everyone, maybe doesn't occur for some, and how far along it might occur in the process of the disease.
I think it's important to realize that when you've seen one person with any dementia, and it's true with Lewy body too, you've seen one person with Lewy body. Each person's going to respond differently to the situation, to the disease, and to the medications. It's sort of unpredictable. I call it a roller coaster ride, the highest and lowest roller coaster you ever want to be on, and also a disease of many faces. But that, go back to what was your focus on the question?
Folks who are interested in hearing about the memory loss portion of Lewy body.
Yeah. Memory does not tend to deteriorate as fast as Alzheimer's, and I think Angela mentioned that earlier. My memory is still very good. It's the processing and retrieval that bites me. I know that memory's going to go down. I have seen some changes, but I tend to be able to recall it. It just takes me longer. I do see people, though, that have Lewy body that have far more significant memory problems than I do, and I don't know where theirs is processing and retrieval or what, because Angela may have some more comments on that.
Angela, do you have anything you want to add, or should I move to the next question?
No, I'd be happy to add something. Most people who have LBD will also have some degree of Alzheimer's changes in their brain as well. We don't know what creates this cascading effect, but this is one of the reasons that the cognitive symptoms vary from person to person, is that depending upon the amount of each disorder's pathology or changes in the brain, they may actually present with slightly different symptoms. I originally thought my dad had Alzheimer's disease because he was seeming to forget a lot of things, but it was also that he was having problems using skills and logic that he had always been able to use. So I saw both memory and executive dysfunction in him early on. Later on, as the more I learned about the disease, I came to realize what I was probably seeing that I thought was memory was loss of attention. So again, I think it's about what the individual is. They may present with some mild memory loss, or they may have symptoms that are mimicking memory loss.
I think there's another factor in there too on memory is how much you continue to stimulate your brain. My neurologist has told me that cognitively I'm doing as well as I am because I continue to read articles, I continue to read abstracts, I continue to push my brain with brain games, and for all too many people sort of give up, and that's why I like to focus on the living component, because we've got to not let the disease destroy us, but fight it and do the things that we know to do to have a better quality of life.
Great, thank you. Angela, we've had a number of questions come in about common age of onset. You mentioned an age range, I think, of 50 to 85. A few folks have asked about, does it become more common as people age? What is is there a typical age that people get diagnosed at, or really is it that wide range of 50 to 85?
It is more often an age of more senior adults. I think when we look at the research that's being done, people who are 70, 75, 80. But my father had symptoms early. He certainly showed some symptoms in his late 50s. Again, it's really different based on the individual. I think diagnoses are often delayed quite a few years after symptoms are first noticed. Again, there's a number of reasons why the diagnosis may not be made early. Whether that's denial on the person who's experiencing those symptoms, the family doesn't recognize because there's changes, they can't quite pin what problem may be going on. But I think that, again, a lot of this is based on an individual's own makeup as to their lifestyle, their genetics, exposure to things. We still don't know what causes this disease to trigger and why some people are prone to develop it at earlier ages versus later ages.
Great, thank you. We have time for a quick answer to one more question. Quite a few people have asked about strategies for dealing with some of the behavioral symptoms and how to manage those, like people who may be resistant to self-care, such as showering or taking needed medications. Are there any strategies that you have found work, or strategies that have been shown to work through research?
Well, so that's a really, it's a big question. We can't really address in depth at all in the short amount of time we have. But I would say pick your battles very carefully. There's very few things in caring for somebody that absolutely must be done right now. If they don't want to shower, what's the harm of them going a few days without a shower? If they don't want to take medicine, respond to them, of course, right now. Come back to them in an hour. See if they've change their perspective. I think, we sometimes create, as caregivers, we create our own challenges, and it's a matter of stepping back and being as objective as we can and taking ourselves out of the equation of what we think we want in that moment to find out what's really best for the person living with LBD.
Great. Thank you so much, Angela and Robert. Again, I'm going to turn things over back to Steve now, as that was our last question. And Steve, I know that you have a few closing remarks.
Yes, thanks very much. Wonderful presentation, everybody. Lots of great information. I want to thank our presenters for being with us today. Robert and Angela, thank you so much for being here, as well as Sari for navigating us through the bulk of the presentation. It's time for us to wrap up, everybody. It is the end of our hour here, so we're just about out of time. But we want to thank you all for joining today's webinar. This